So thank you, and thank you, Richard, for your talk. And I think you've given me an idea now of what I can talk about. So I was looking at the question that was posed, whether, technology is it a fallacy? Is it a future in the NHS? And my feeling it's both. My background is a surgeon. A few years ago when we were introducing EPR in Calderdale, and Richard mentioned Owen, and Owen was incredibly passionate about technology. I was one of those that sat there laughing in a clinic, saying, "What are you doing this for? This is ridiculous. You're getting all clinicians to suddenly change what they do. It's going to be a failure." And I was laughing. I remember at the CIO at the time, she still reminds me. And it worked. Technology really worked. EPR, we went big bang. Everything worked really well. Clinicians really happy. A few months later, I became a CCIO at Calderdale, and I came responsible for the technology. And since then I've really pushed it. I've seen the benefits, and I've seen the energy that technology and digitization can bring to an organization. But what we seen during COVID was something very different. And this is where the fallacy bit comes in. We've all seen a huge explosion of technology. We've seen every trust sending their workforce home. We've seen clinicians doing virtual appointments all the time. We've seen technology adopted, not necessarily because people wanted it, but people had no choice but to accept it because they couldn't be in that environment. What we're seeing now is people are still adopting, but we're seeing the old ways coming back. There's a recent paper, I think, from the American Academy looking at virtual consultations in America, and they're now gone back to pre-COVID levels. So to Richard's point, we have to think differently. We have to not replace what we have with tech, but we almost have to re-look at healthcare. How do we deliver healthcare? What's the center of what we do? And the center of what we do is not an organization such as Calderdale. It's not a GP's practice. It's everyone together, and the patients are the focus of that kind of conversation. I was, wondering again what to speak about, and I normally can just waffle about anything, really. It's a shame Paul Rice isn't here, because, I did have a joke about him, because normally when I'm in a meeting, I can't get a word in edgeways, so it's nice that I've got 10 minutes. So Paul, if you're watching. But one of the, the things we've seen, is we've always worked in isolation, silos. A patient sees a GP writes a letter to a consultant. A patient comes in to see a consultant who says, "Oh, your GP's rubbish, they've written this," and various things happen to that patient. But how if we turn it on its head, that the patient becomes the person that controls healthcare? That patient goes online. They enter a virtual world where they put in their symptoms. Their symptoms direct them to where they need to be, whether it's with a physiotherapist. Now, I'm going to speak in an MSK perspective, being a knee surgeon. It's all I don't understand any of the kind of technical stuff for medicine. That patient then is directed to a physio. That patient is directed to some self-help, whether it's through an app. I saw NHS Expo yesterday, and it was a really refreshingly informative meeting that we had in the region. They were looking at, I remember when I interviewed for the CCIO role, I talked about healthcare in their hands. I talked about, the hospital, well, actually, I think it was hospital in their hands, that, we were moving away from buildings, we were moving into a virtual space. And they're now talking about healthcare in their hands. So, the patient, the citizen, whatever you want to call them, they go online. They are triaged to the right people. As a knee surgeon, some people do need surgery. They're going to come and see me in clinic. By the time they've come to clinic, they've used the tech around them. They've filled in scoring systems. All the pre-work is done remotely. Questions are asked that need to be asked. Investigations are done prior to the consultation. But do I need to see them? Probably not. Am I going to do a virtual consultation? Virtual consultations replace normal consultations. But that's not cool. People will not adopt that. We'll go back to the old way. I like seeing patients. It's nice. They pat you on the back. They say how wonderful you've done. They bring you bottles of wine and write you letters. I like that. Does a patient really like that? Does a patient want to wait for me for 3 hours because I'm doing a meeting or I'm running behind? Do they want to pay £10 parking in the car park? Do they want to take an afternoon off work? The answer is probably not. But we as clinicians think they do. So give that experience, enrich that consultation. That patient comes to see me virtually. In that consultation, We can see their x-rays, we can see the scores, we can see everything about them. You know, we know from remote monitoring their range of motion. We know how they're doing. We have that entire kind of that experience. It enriches the experience. So virtual becomes better, not a replacement. And that's the key. Digital shouldn't be replacing things. We should be using digital to almost change how we practice. You know, so let's go back to the scenario. The patients see me virtually. I've listed them for surgery. I've done their consent, and I've done it virtually. And the patient gets the information. Now, consent, when we do it in clinic, it's a bit of paper. I can't read my own writing. The patient can't read that writing. That is done and they go away. Virtually, they get a script. They get a load of, you know, things that they can read, things that they can digest. Consent is done better virtually. That patient comes to theatre. I've tried this virtually, it just doesn't work in the kitchen. I do need them in theatre to replace the knee. However, imagine we use robots. You know, we have robotic technology now which assists surgeons. It makes probably a good surgeon more predictable, but doesn't change a bad surgeon into a good surgeon. Surgery sometimes in MSK particularly is about decision making. When I do a knee, I look at the knee, I look at the patient, and I decide, you know, the best way for that, you know, and I'm going to show off, I've just done 2 knees before I came here today. But, you know, I instinctively know as a surgeon what's good for that patient. But using technology, you know, so, you know, we put the patient demographics in, we put their gait pattern in, that robot knows if you do it this way, that patient's going to have this outcome. We can tell the patient that preoperatively because we've already made that assumption. When the patient's in theatre, that robot can help guide me as a surgeon to know that my variability, you know, for example, you know, as a knee surgeon, we think, you know, every surgeon's better than the next one and every generation's better. But for the past 20 years, nobody's really improved on 80% satisfaction rate from joint replacement. You know, we think we're much better than we were 20 years ago, but it's not improved. So that's where technology can improve some of those outcomes for us and help us with that. So we then go through the journey. The patient has a robot with them. I have a robot with me. And we do the surgery. They go back to the ward. You know, a lot of what I do, and I think I've mentioned it, I kind of like it, so I talk about it a lot. I do day case surgery. 60% of my knee replacements now is done as day cases, you know, partly through the technology that we use. So we use that tech. And what is that tech? That tech's wearables. You know, the patient has a monitor. Traditional methods of recovery after MSK surgeries, we send a patient home. They'll come back to see the physio 2 weeks later. That patient's only got 2 knees. If I've only replaced one of them, it's their first experience of that operation. They don't know really what happens when they go home. Wearable technology, dashboards, that helps them. They know that they're achieving their set goals. They reach their goals. They know they're moving on to the next stage. They know they're doing well. If they're concerned, they can message us. That's a really quick thing rather than, you know, ringing the GP. The GP rings my secretary. My secretary leaves me a note on the desk. I work virtually. I don't go into my desk, so I never pick that note up. But this way, a patient sends a message straight away on a dashboard. We respond to it. And again, that is using technology in a different way. You know, we're changing, we're turning that pathway on the head. And then what happens when we come to the follow-up clinic? Again, we normally see them in clinic because we need to see them, because we need to see that we've done an okay job. We need to see that the patient's doing well. But if we've got wearables, I can see they're doing well because I can see the range of motion. You know, we can use the technology to look at the wound. And when that patient doesn't come to clinic, they're seen virtually, they're probably at work. So they can dip in and see me from work and it doesn't disrupt their day. It's a much more efficient model of care for both the patient and the clinician. But what's the barrier to this kind of lovely, fanciful world I'm talking about? The barrier is the clinician. It's people like me. It's people that sit in the clinic and say, oh, no, that'll never work. Why should we change? You know, we've got to change that model. You know, we've got to bring those traditional models, you know, away. We've got to use technology, again, not to say, let's replace something. Let's do it differently. You know, let's work together with primary care. Let's turn hospitals into places where it's just the one place you have to go because you need to go for surgery. Let's do everything else as distant as possible. Let's move the hospital into the cloud, as it were. You know, I'm sounding like NHS now, aren't they? Healthcare in their hands. But let's do that because it's there. The technology is out there. You know, and what HSN and people are, you know, and you guys, you know, you have to, you know, the conversations you probably have a lot are with IT people, and IT people love technology. When IT people talk to clinicians, it can be quite cold. But technology can be really, it's often seen as a cold thing that distances a patient. Wearable technology. When I was doing day cases, people were saying, "Oh, God, you're sending patients home really quickly. That's really bad of you." You speak to the patients. They loved it because they felt somebody was watching them. When they went home, they were being monitored. They felt they were part of that team, and they became part of that team, and worked with the team, to deliver the results. So I think that's what we need to look at. I think the hardest thing at Calderdale, we're very tech savvy. We've got loads of stuff. We hardly have any paper. But one of the hardest things, just jumping out the window, it must be that boring. I'm really sorry. But one of the things that we really struggled with is voice recognition. And I hope Owen's not watching this, and I do apologize if you are. Because voice recognition was asking people to change what they did, but wonder why. Because actually, it's really easy to use your finger to type. It's really easy to press a button. How many people in this room speak to their car when they're on a ring someone? How many people use voice recognition in the car? Nobody does it? It's there. And I think that's the problem with tech. We need to make sure it has a value and it's going to improve things. Automation, all that kind of stuff, it improves things. Virtual experience improves things. But unless we get that bit right, and unless we change the way that we look at how we deliver healthcare, we're going to go back to how we were pre-COVID. And that's not something that we should be doing or need to do. And I think, if we adopt digital globally across the NHS, and if it is, as NHSX say, it's going to be a patient-facing dashboard on the NHS app, that would be fantastic. So everything that DrDoctor does, everything that EQL does, everything that all the other companies do, feeds into the back end of that app, and all the patient sees is that front end thing. Now, I've done 10 minutes. Oh God, I don't know what to talk about now. And I think that's, the key is we can be fantastic digital adopters, and we have been, but we're going to go back. And I'm seeing now already in the hospitals, people that were working from home are kind of having to come back in, and you wonder why. I had the fantastic experience yesterday. I was doing a clinic, and it wasn't virtual because I had to see these patients apparently because I'm a doctor. But the room next door to me was doing a virtual clinic. But it was really odd because I was in the hospital. The patients were coming into this TIA clinic, stroke clinic, with the nurse, and it was the doctor that was at home. So they were going into that, and it just struck me as we've got this wrong. We're kind of embracing it, but we're not embracing it really well. And we've talked about the digital deprivation, and are we going to exclude parts of society because we're adopting digital? All these conversations have to involve the patients. They have to involve much bigger conversations. We need to have traditional methods still available to us. But we also have to look, one of my big things when I first started as a CIO, I kind of contacted Barclays, Digital Eagles. I thought, they did it. Let us do it too. Let's have hubs. Let's have patients can go into a digital hub rather than the hospital. But that's what we need to look at. Actually, we don't have to exclude these people. We just need to bring them in. We don't have to send them an iPad at home or a laptop at home or have a smartphone. A lot of the work I do with my day case knees, it might not be the patient that's got the iPhone that links into the wearable. It might be a relative. It might be someone that pops in. So we need to think smart rather than just saying, oh, we can't do this because the patient hasn't got the smartphone. When we say that elderly people can't use it. I was on the ward. I was on call. I still do on calls. Owen, if you're watching. But I was on call on the trauma ward. And there was an elderly lady who had fractured neck of femur. I think this kind of summed up digital to me a little bit. She was there with an iPad, reading the newspaper. I thought, this is great. But she was reading it with a magnifying glass. And I just think she didn't do that with her fingers. But it's the same way that many of you, I'm sure if you pick up a newspaper now, you're trying to do this all the time. But it sums it up. People have adopted it. And even the elderly people can adopt, that kind of thing. And we shouldn't stop innovation because we're scared about that, that other side of it. Healthcare is there for everyone, We just need to make sure we channel the right models of care, and if technology works for 90% of people, let's adopt it for those 90% of people, and that their 10%, the other 10% will be done in, we for example, with the, staffing levels are massively down. What we're doing now with the digital day case stuff, where the patients are going home, they're not needing physio appointments because they're doing their own thing, and they're doing their own thing really well. But there are a group of people that need those physios. Those physio are a scant resource. We can now make sure the right resource goes to the right people. And actually when we've got to reduce workload, working a bit smarter, we know that we haven't got as much staff. I go into the hospital these days and lists are down, the wards are empty. It's not a nice world to see. And that's what COVID has kind of brought us. We've got an exhausting, as we said, we've got a workforce that are tired. We have to use anything we have, whether it's the frontline clinical stuff or the RPA in the background, the automation. We need to look at that processes and try and simplify it for many people. And that way we can move staff around to where they're needed, doing the job they want to do, but at the same time delivering care to the people where they need it, and that isn't in a hospital. That's healthcare in your hands, at home. Am I 10 minutes yet? So I don't know whether there's any questions, because I could go off on a tangent and talk about something else. I get carried away.
So I feel about the sorts of digital first.
Yeah.
What do you think some of the challenges are?
I think some of the challenges, again, to adoption are the people, and I think some of that is not necessarily because we don't sometimes engage people. Sometimes, and what I've seen, and it's in every organisation, not just our own, is that we think this is a good idea, let's bring it in and let's force it upon people. So what we do a lot of now is that engagement work beforehand. We make sure that the right people in the right room. We don't just go out and get tech. We make sure there's a need for that. We look at the processes, because if you've got people buying into it before you've got it, you've got that engagement. If I'm honest, I don't ever see a negative in these things, because there isn't. There are some things, the technology, will always deliver a positive, but we've got to make sure we engage the people to make sure they're part of that journey. We're not forcing it on them.
Who do you think are the best people to champion that digital change within trust?
So again, I mean, again, as I say, I was kind of a real not skeptic. I love tech, but we all kind of love tech at home. Everyone's got an iPhone and everyone does all this thing. And, when it comes into the workplace, tech kind of challenges traditional things. So me as a surgeon, I orthopedics, we see people that's, we have set things in our world, and we to deviate from that is difficult. And I think we need to take people with us. Now, we've talked about digital champions, and CCIOs traditionally, I think, and I feel, and meeting with them, seem to think their role is about the tech. They seem to think it's an IT role, and it kind of is, but it's more transformational. And the engagement piece is probably the key to this. I'll go to meetings with CCIOs, and they're all kind of really excited that they know the acronyms. And, when I started, and Owen was really good at this because he knew we didn't know what they meant. So we'd be writing, what does API mean? And all these things in our hand in the meeting, because he would say, oh, what does that mean? But he recognized very early, my role is not to know what the tech is. I need to know what it does, and therefore what value it can bring to the organization and the clinicians. And I think that's where we have to change. We have to move away from everyone in that digital team. Digital's not digital anymore. Digital is how we work. It shouldn't be seen as a digital. We should be seen as transformational. We should be seen as part of the interwoven in the tapestry. My role doesn't just fit. I kind of cover everything, every aspect of something at the hospital. There's a digital aspect, and I kind of get involved in that. But what people have to do is not turn to me as the CCIO. It's their world now, and they have to realize that digital, is part of the organization, and actually they can make a change too. They don't have to look, well, we'll send Mr. Walsh an email and see if he responds to it, and he hasn't responded to the 7,000 emails he got today. but people need to embrace that and move. And we can help them with that change because we know the right people to get them in touch with, but they need to look around, and whether it's meeting guys like you, or other people, they need to engage, and it's and realize that digital is not there anymore. Digital is all around us.
Graham, thanks very much. I'm going to challenge you now about what the future looks like. So
you're on the sleeves of it.
No, it's nothing physical. So, not with a surgeon anyway. First of all, it's an observation which is about language, and I think language is changing because you very nicely highlighted this challenge with language. When we talk digital, and those working in IT speak a different language from clinicians, and I think that's an enormous barrier. But I think that barrier is starting to break down now as the younger generation come through. And there is no doubt, speaking about the younger generation across the healthcare workforce, it's different. They're starting to think differently, the challenges are different, their ability to look at things in a different way through a lens that is supported by innovation and technology is also different. And what will happen in 20, 30 years' time will be very different to what we're experiencing now. So I've been in healthcare, qualified 23 years. What happened 23 years ago now is they're light years away. So what's going to happen in 23 years? So I'm not asking you to predict the future, but I'm actually putting the challenge there. What will the healthcare workforce look like in the future? Will we have primary, secondary and tertiary care? Will we have doctors, nurses, physios? Because actually many of the healthcare professionals outside doctors are doing the job that doctors would have done many years ago. So those kind of ancient, and they are ancient, titles and paradigms now are changing. Do you think we will be referring to people as doctors and nurses in the future? I'm sure we'll need surgeons, of course. We'll always need surgeons. Robot surgeons.
And I think you're right. The world is changing. My wife's, is a nurse practitioner. She's kind of doing the role of a GP. We are, in the healthcare, we've got, we physicians associates. We've got ACPs, advanced care practitioners, doing the role of a doctor. We've got the technology that's replacing a lot of the things that we do. Why does I'm sorry if there's a diabetologist in here, an endocrinologist, but oh my God. But it's true. A lot of what we do. When I was a medical student, I used to sit in a diabetic clinic and the patient would come in to be given blood results. And actually a lot of that care can be delivered not necessarily by the clinician, because there are algorithms that people can follow and pathways. Where the clinician needs to be is that kind of the tricky bit, the decision-making bit, and whether we sit in in a more kind of, that kind of cloud base. Some of the great work, we have Cerner EPR. And so I was lucky enough to go to speak at Cerner's health conference a few years ago before kind of COVID destroyed the world. But what we saw there is, fantastic. You'd have the diabetologist come into the hospital in the morning. They'd put the computer on. It would give them a list of all the patients that had, abnormal, bloods that they would need to. They could remotely, from that, give advice. So it's almost, as a consultant, you may be more in a advisory role, potentially. And that technology will allow us to do that. Some of the, the AI, the predictive stuff, the learning stuff is going to massively change how we deliver care. We already have it in radiology with chest X-rays and, scans for strokes. The difficulty is who takes responsibility for those decisions, potentially is the conversation we'll have. But I think we, even as surgeons, we've already got surgeons sitting in a room with a robot and a joystick. They don't need to be in the room, do they? They could be somewhere else. So things rapidly change, and the first step in that is what we've got at the moment is that digital adoption, which I think we're beginning to get. Digital adoption comes with people start to accept things more. You know, when I was, you know, even as simple as sending a patient home the first day, oh, you're cruel, you're nasty. You know, what happens to the wound when they go home? Well, the same thing it would have happened if they're on the ward. You know, so we're breaking those barriers down. But I think in 20 years' time, I think institute, we won't have the big hospitals. We'll have, you know, elective units where we do certain bits. We have central hubs where, you know, we're monitoring technology. We're getting feedback. We've got different, you've got, whether it's associates or nursing roles or completely different roles, that doesn't take 6 years to train and then a further 20 years to train to become a consultant. The roles will change, and I think technology will hopefully give us a more predictable outcome for patients, because at the end of the day, that's what we're here for. We're delivering healthcare, and there's a patient at the end of that, so we need to make sure everything we do is safe and predictable. But going back to some of the earlier conversations, these things will, we need to look at population health. We need to look very at the beginning. Patients shouldn't be getting sick, and that's it. Are we going to, we give dietary advice, we give health advice at the very early stage so that they don't come through the system and need us. So, we're potentially doing ourselves out of a job. Luckily, I think I'll be retired by then. But I think that will, population health will, at the very beginning of that journey, whether it's welfare apps, some things, how far has the Apple Watch moved in the past few years? Imagine that in 20 years' time. You'd be like Star Trek, isn't it? You kind of those little sensors and moving people around. It'll be all called Dr. Scott.
Right, can I offer? I give an interest here. So I'm not in health, but I'm on the board of health at group hospitals, but I have 30 years in aviation. And I want to pick up on something you said earlier on about the joining together of professions. So what you've just described about preventative medicine, potentially, it's already there in the industry for machines. I'm not trying to say that humans are machines, but it's already there. The technology is there. In fact, it was stolen from the health service. It was stolen. The aviation took it from the health service about monitoring vital signs and monitoring thousands of people of aeroplanes and equipment flying every single day, keeping them safe and keeping them ready for use every day. We're not worried about it because they're machines, and there are people sat, as you describe it, experts, surgeons, making decisions from data and trends well ahead of time. And you can bring it like that to birth, how are you going to make that, how are you going to design that. So it's there. We just need to work together, frankly. It's there, but the adoption piece, I mean, me as a member of the public, I've got to sort of be happy now that someone monitoring how I'm behaving. And I think we've seen the app, haven't we? So I'm saying the technology's there.
I think one of the most kind of sinister, but probably the most enlightening things, going back to that Cerner thing that I went to, Amazon control the world, pretty much. Control my world at home because they spend an awful lot of time visiting. But they sit a lot of the clouds. So I went to a talk from Amazon, which now are the cloud that Cerner sits on, and a lot of the healthcare companies sit on too. And they were looking at very similar to that. We are a commerce company. We will use the data to know what food we deliver through our food market. We will use the data to know what books we sell. We will know, and overriding this, we've got a pharmacy, but we've got the biggest logistic company in the world, and we can deliver this. So, let's get real. Industry have been doing it. DPD. You can track everything. We should be tracking patients. We should be tracking not just patients, people's health. And we need to learn. And I think what we as healthcare, we see ourselves as slightly different to everyone else. We need to learn from industry, because you're right.
The algorithms which control come from the experts in healthcare. They not come from someone,
and we need to learn that and adopt that. Because I think that, we need to be less fearful. I know IG is incredibly important, and I know we're changing the world with regard to that currently with NHS looking at those things. But we need to, if we're going to embrace change and we're going to have this world, some of that, acceptance of some of that, learning from our health records, learning from our personal data, we need to accept that, because actually ultimately that is going to deliver better care globally, within the, not just to the individual, to whole population health. And I think that's important.
Any other questions?
Yes, just a quick question about yourself, really, as a surgeon, and going back to when you took on the idea of change. I think I just wanted to, it's a two-part question. So one is looking back at that moment, that pivotal moment where you were working in a more traditional mindset and working ways. And what was that moment that you thought you wanted to engage and understand what systems you were going to take on board? And then the second part to that is, how do we extract that pivotal moment from other clinicians and get them there faster? Because when it comes to implementation and you're looking at an exhausted workforce, how do you get somebody who's in a stretched mindset and a clinician who's used to traditional methods to get to that pivotal moment where they will look at that change and be open-minded to think, actually, if I just take 2 minutes to invest my time in this could be something that helps me down the road and for the team and for the place that they're working in. So it's a two-parter. What was the pivotal moment, and then how do you get that from someone
I think
else?
my kind of journey of change was never pivotal. It was incremental change. I'm one of those that will always question everything. I'll always think, well, why am I doing this? And it's because we've always done it. We hear that so often, particularly with clinicians. Why are you doing that? It's because Mr. blah, blah, blah used to do it. And well, why are you doing it? And then you question. And so a lot of healthcare is about tradition and not challenging your hierarchical, my boss did it this way, I'm going to do it that way. I was a little less than that, so I was looking at making small changes. And when you make those small changes, you see that actually that's, a simple thing. I mean, and I know it's not tech, but it's, it's a very simple thing. I was in theatre one day, and everyone that gets a knee replacement, you'll see they get woolen crepe wrapped around the knee. It's really bulky. And I just thought, why do we do that? So I just one day just said, let's not do it. And actually, about 2 hours later, the physio came down to see me, and I thought, oh God, I've done something really bad. That was a mistake. But she said, what have you done? And I was like, oh God, what have I done? I took the woolen crepe. I said it was fantastic. Suddenly, I could get the ice on the patient quicker. I could get them moving quicker, and they were doing, they were rehabilitating quicker. So, those changes, some clinicians find hard to do because it's breaking, and you're going to have innovators. Naturally, there's going to have to be people that do the innovation, but then my role and our role is to feed that back, and to give that message out. A lot of what, with the day case work, I get a lot of people asking me for this silver bullet. How do you do it? What do you do? I said, I don't do anything. The team does. If you want to learn it, you come and see it. And they see the whole, you've got to take everybody on that journey. Your patient's there as well. The whole, it took years to get that culture to change in the organisation where I work to allow day case. You can't learn that by ticking a box. You've got to come and you've got to see it. And what we used to do this in the private sector, but then because we were doing it and it was working, we then took our NHS nurses team down to the private to see it. Within 6 weeks of that first meeting, we did a first day case knee at the trust. So once someone's made that change, bring people on. They're like with digital. It's about going to see. Don't just look at a tech and try and bring it in. Go see that technology working, because it's not the tech. It's the way the team dynamic works around that tech is the important. And that's no different from healthcare. That's no different from, what we do on a daily basis. Seeing makes the difference. Okay, thank you.